All right.
Go ahead.
Mark, you're recording? It looks like yes. Okay, great. Thank you guys so much for attending October case reviews. An effort to try to keep within an hour. It's one less case. I believe that we'll have one presenter. Let me take a quick look at the participants to see if they are on. I don't see them, but their case is the third case, so we'll see if they show up. All right, so as always, this information is confidential and it should not be shared or distributed or copied with anybody outside of our organization. It's uh, protected with HIPAA. And for the first case, it's of a 40-year-old female. EMS was dispatched to, I believe it was shortness of breath. Um, I wrote in here that their diagnosis was hypotension and their secondary diagnosis was hyperventilation. The primary survey is that the patient was unresponsive when they arrived. Her airway was open, labored, she was grunting, she wasn't protecting. Her circulatory exam showed that she had a pulse that was present and there was no active bleeding. The first set of vital signs obtained were 6 minutes after initial patient contact. Her heart rate was 150, her blood pressure was 76/44, no respiratory rate was recorded at that time, and her SpO2 was 82%. She was approximately 65 kilos, and the only past medical history that they were able to obtain was that she has a history of cervical cancer. Her medications included hydrocodone, methadone, Tylenol, Flexeril, famotidine, and melatonin. In the history that they gathered, which I believe was related to her husband on scene, was that she was short of breath abruptly about 30 minutes earlier, and then she developed altered mental status. When she came around and started to be um, responsive, she was able to provide additional information that she had metastatic disease. And she further went on to talk about her shortness of breath was related to her shoulder pain and that she was having chest pain with breathing, but that was only initially when EMS made contact and stated that it had resolved by the time that her status improved. So this call came out at 2:40 in the morning. The vital signs that I reported to you are in the first. Oh, I think that I added the 3 minute and the 5 minute to be able to get you guys a most complete vital sign set. As you can see, there's no respiratory rate recorded until 22 minutes into the call. They document that her breath sounds are clear to auscultation. They document in the narrative that they got a 12 lead, but there's not one in the chart. Um, at 5 minutes, she got an IV placed and approximately 500 mLs were administered through that IV. And they checked a blood glucose, which was 70, and they placed her on 4 liters of nasal cannula oxygen that improved her SATs to 99%. At 18 minutes, they reported a temperature of 99, and at 22 minutes, she had um, a heart rate of 142, 97/44, respiratory rate recorded at 49, SpO2 on nasal cannula oxygen 99%, and end tidal of 19. At 28 minutes, they initiate transport. 32 minutes, another line's placed. She was given another 800 mLs of fluid. And at 41 minutes, she arrives to the hospital. Anybody have any questions or comments? In the Pulsera, they document that she's a red. They write in the narrative that she's got labored breathing, she's fatigued, having chest pain with a brief altered mental status, that her SATs were 90% on room air, and that her blood pressure was 74/46, and tachycardic at 150. Now her blood pressure has improved to 97/44, and she's 100% on oxygen, no chest pain at present, and she's A&O times 4. They report the heart rate of 142, blood pressure of 97/44, respiratory of 45, SATs of 99, end tidal of 18, GCS of 15, blood glucose normal. The things that are helpful for us when we get these Pulsera notifications is that you're really wanting to paint the picture of what your initial presentation was. So at no point Did they record in any of their sats 90%? It looks like her lowest was 82%. So 82% is a little more profound than 90%. So make sure that you include that into your lowest findings. And especially if they improved significantly, which they did, they had indicated that her SpO2 now is 100%. What also, if you have the bandwidth to do, is to say on nasal cannula or on non-rebreather, so we have an idea of what her current O2 requirements are. You don't have to necessarily put in the flow on those. Just the device itself helps to broadcast how much support this patient's requiring. So in review of this case, I thought that they did get a full set of vital signs, although it was partial up until 22 minutes into the case. They managed her airway BLS when she was unresponsive, and it seemed to appropriately improve with the nasal cannula, and they appropriately categorized her as red triage. The documentation, I thought that hyperventilation in any part of your diagnosis for this or your impression of this patient is inappropriate, as she has multiple vital signs that suggest that she's not hyperventilating, that she is compensating for some other process. If that would be for, reactive airway disease, pneumonia, PE, whatever the case, but we have a patient who's profoundly tachycardic and hypotensive and tachypnic. So I don't think that hyperventilation is truly the appropriate impression on her. The serial vital signs, they could have been more documented based off of the 41 minutes with this patient, as we only have a few set of vital signs and quite a delay in getting a respiratory rate reported. And then lastly, the consideration for a differential diagnosis. And then the other components would be consideration for a dyspnea and sepsis protocol. I think that the charge nurse that's looking at her Pulsera can probably determine based off of what was in there, because I think in the comments they wrote that she had a history of cervical cancer, that they could extrapolate what her differential diagnosis might be. But having that broadcasted across to the hospital receiving is helpful. Yeah, I think that's the major stuff that I have to say. So in the emergency room, she has a set of vital signs that are reported afebrile, still tachycardic, blood pressure 118 over 71, respers of 33, sats of 93% on 4 liters. They noted that her eyes were jaundiced and that she was in moderate respiratory distress. She received antibiotics, blood cultures, as well as platelets and blood because of profoundly low cell lines across her white cell count, her hemoglobin, her platelets. She got IV fluids. She became hypoglycemic multiple times, required 2 amps of bicarb or 2 um, 25 grams of D50. And then because of her recurrent hypoglycemia, she was placed on a dextrose drip. She was hypotensive, requiring norepi, as she was not responsive to IV fluids. This is all in the emergency room. And she also received albumin, as they thought that that might be contributing to her hypotension as well. Her lab showed that she was acidotic at 7.24, bicarb or PCO2 of 36 and bicarb of 10. So looking at metabolic acidosis, her lactate was 11. Her D-dimer was obtained probably for her high risk for having a PE. That's elevated, high risk for the fact that she's tachypnic, she's hypoxic, she's tachycardic, she's got a history of cancer. Her potassium was pretty low at 2.5. She was an acute renal failure. And then the glucose of 53. Her hemoglobin was recorded at 4.8. To give an idea of what that looks like in context, is that normally the values are like 14 to 16, and we typically transfuse around 7, so she's pretty low. And then she's got a very low platelet count of 9. Her mag's a little bit low, and her imaging shows they got a CT of her chest, PE study, and it shows that she has right greater than left pneumonia. This is her CT. You can see this side is the right side. Here's the left side. This is more typical lung parenchyma. You can see that there's a lot of an infiltrate or pneumonia on that right side compared to the left. Um, she made it to the ICU. They shortly after she arrived intubated her as they could determine that she was going into decompensated respiratory failure. She had a central line placed and she was started on a bicarb drip as well as pressors and IV fluids. She suffered a cardiac arrest on hospital day one, PEA arrest that they were able to achieve ROSC 17 minutes into it. And at that point, her husband made her a DNR. Afterwards, she was placed on 3 pressors and a bicarb drip, but still not responding. She ended up having an asystolic arrest and was pronounced dead on hospital day one. So this case I brought up, not so much that there was any complaints or any concerns or any self-referrals. It was more of the fact that I was involved with her care 2 months earlier and then found out that she had passed away. So I thought that this was a good case to talk about. And then the passed away, and then looking at our chart for the pre-hospital side, looking that we could do some work on improving some of our documentation. But so she actually didn't have per se cervical cancer. She had neuroendocrine tumors. So I thought I'd talk a little bit about neuroendocrine tumors, and I think that that led me to the second part of this kind of like knowledge to discuss. So neuroendocrine tumors, or abbreviated as NET, these are also known as carcinoid tumors. They're pretty rare. There's usually about 12,000 cases per year in the United States. For the most part, it's not inheritable unless you have a predisposition in your family of acquiring MEN or neurofibromatosis or von Hippel-Lindau. Um, and if you have any of these genetic conditions or you have a family history of these, it increases your chances for neuroendocrine tumors. This is a cancer that originates from endocrine cells, in that these are cells that regulate body function. So you may think neuroendocrine, thinking that it has to be the brain, but these are actually going to be like your lung, your intestine, your pancreas. Um, and then most neuroendocrine tumors do not produce hormones. Generally, these tumors are cancerous, just various stages of growth and various stages of mortality. In that the signs and symptoms for patients with neuroendocrine tumors is that they can be completely asymptomatic. They can have some symptoms related to hormonal release. So their blood glucoses may be difficult to control despite intervention. So, like in this case, she ended up having hypoglycemia, no history of diabetes, multiple times resistant to repletion, and ended up being on a bicarb or a dextrose strip. And then they may have GI symptoms such as diarrhea or irritable bowel type symptoms, or they may develop an ulcer from increased acid secretion from her hormone hormone releasing, or it could be obstructive. So the tumor gets so large that it impedes a process such as developing a bowel obstruction. Um, and the treatment, depending on the depending on how severe the disease is, how advanced it is, it could be like surgical, where they remove just the tumor of origin. So like sometimes you'll see like carcinoid tumors of the appendix. It could include somatostatin analogs, which work to decrease the hormone production that these tumors are stimulating, or it could be targeted therapies related to certain aspects of the cells that the tumor has that try to target directly those cells, and then chemo and radiation. And this picture over here kind of gives you an idea of where neuroendocrine tumors can manifest. So could be lung, it could be pancreas, it could be bowel, it could be thyroid, it could be adrenals, it could be ovaries and cervix. And in this particular patient, when she first presented to our emergency room in the end of July, this was her CAT scan that showed multiple pulmonary nodules, diffuse, as well as hilar lymphadenopathy. And that got me kind of thinking about how she presented her first presentation back in July and also how she presented in October, where um, she kind of in this presentation for this case review, she had told EMS that her shortness of breath was related to her shoulder pain, and she didn't really describe any kind of infectious symptoms despite this pretty significant pneumonia. So not really any fevers or any productive sputum. Um, and then the other thing is that she also there was something else that she had reported to EMS that kind of played down her presentation. Let me just try to remember. Oh, that she had said that she was only having some chest discomfort with breathing, but that had since resolved. So she's kind of doesn't really describe the story um to knowing her outcome, knowing her diagnosis as severe as you would expect. And I will say that when her first presentation, she had stated that she was having she initially presented to our emergency room complaining of back pain that radiated down her legs as well as groin pain. And she had stated that it was from participating in a dragon boat race a month earlier, and that she thought that it was just not getting any better. And that she was having so much weakness with this that she was using a cane up until the day that she presented, where her husband had to carry her because she was too weak to walk. And then as you kind of go into more of her review of systems for that presentation, there was a minimization of her 21-pound weight loss over the last month, as well as her productive cough, and some blood tinge component to it. And based off of her exam, where she had bilateral lower leg weakness, that would be pretty profound for a 40-year-old woman who was previously healthy, which is what prompted the imaging of her spine that showed she had metastatic disease to her spine, and then further to find out that um, she had disease, metastatic disease to her brain, her pelvic bone, her spine, her lungs, her lymph nodes, and that her um, into her cervix and uterus, and that her diagnosis was a neuroendocrine tumor of her uterus that had metastatic disease widely. So, kind of the complexity of a patient whose perception of what their symptoms are and also their diagnosis makes our job challenging. Not that I'm giving any flack, but it just more of my thought it would be a great way, a great opportunity to showcase our patients try to explain what they think is going on in their reality, but we have to use our physical exam findings, our assessments on our patients to try to gather and interpret that information to determine what actually is going on, especially if there's anything significant that needs to be identified. Um, for our protocols, respiratory distress and sepsis. In this patient, she was tachypnic, hypoxic. She was reported to have no airway obstruction. Her breath sounds were clear. So really not really falling into any of these categories. If her respiration was insufficient, you could rule out potential for obstruction. Really, when we're talking about is, our elderly patients potentially associated with eating or picking up a patient in cardiac arrest at a restaurant, especially if alcohol is involved, to consider that, or potential overdose with a trial of Narcan. Um, and then going back to, I think that there's a cutoff here. There should be a CHF exacerbation, which she wasn't having that condition. Um, and then sepsis protocol, looking at this, I think that we could have called her a sepsis alert earlier, but nonetheless, it was identified. And I don't think there was any harm in the delay in identification until she arrived. But maintaining stats above 95%, which is what this crew did do. She wasn't febrile, she wasn't hypothermic, but her respiratory rate was elevated, her heart rate was elevated, and her end tidal, I believe, was also low. Um, if two or more of the above and hypotension or altered mental status meets the criteria, give up to 2 liters. We want to aim for MAPS above 65, make sure that we're not developing volume overload from our fluids. So looking for JVD, looking for reassessing lung sounds, and if they're not responding, consideration for pressors. Anybody have any questions or thoughts that they'd want to add?
No, I think that's a good explanation, and I think putting those vital signs together really does paint the picture of sepsis.
Yeah. And of course, hindsight's 2020, but I think that based off of what information, even the cancer diagnosis and stuff like that, that helps you in trying to put the information all together. Excellent. So going on to case 2, just gonna I'll double check on case 3, if we have our guest. So this case of a 75-year-old male. EMS goes out for chief complaint of syncope. They find the patient to be alert. His airway is open. He was protecting it. They note that he was pretty cold, clammy, with poor turgor, and there was no signs of active bleeding. They obtain a set of vital signs pretty early on at 0 minutes. Heart rate of 77, blood pressure of 102/63, respiratory rate of 16, and SpO2 of 93%. Weight is estimated at 113 kilos. The past medical history that they have is asthma, COPD, hypertension, lung cancer, type 2 diabetes, and sleep apnea. And the medications for this patient include albuterol, atenolol, atorvastatin, baclofen, bupropion, clopidogrel, duloxetine, famotidine, fluticasone, gabapentin, isosorbide, Jardiance, Lantus, metformin, Ozempic, pramipizole, tamsulosin, trazodone, and finally, that's the last one that's reported. The history that EMS gets is that this patient suddenly became nauseated while sitting and watching TV, then had a syncopal episode witnessed by his wife, noted to have hit his head, and he was also on blood thinners. This call came out around 5:44. The patient's complaining of neck and back pain, although he tells EMS that this is chronic. The vital signs, as I had previously reported to you guys, and at 12 minutes, an IV is established. He has a chronic O2 requirement, which is at his baseline. And at 18 minutes, they give some fluids and they give 8 milligrams of Zofran. At 19 minutes, they get another set of vital signs. Is a little bit he's a little bit hypertensive, but his blood pressure is moving in the right direction compared to his initial. So heart rate 65, blood pressure 154/131. The diastolic, I suspect that this is probably an inaccurate blood pressure. So worthwhile to either check again or to do an auscultated, as the pulse pressures are pretty narrow. Respiratory rate of 22, SpO2 is reported at 85%, and blood glucose is 187. At 25 minutes, they get a 12 lead. Looking at this 12 lead, it appears to be wide, complex, but more consistent with a bundle branch block, regular sinus. So reading that as sinus with a normal axis, right bundle branch block, and no ST elevation. At 26 minutes, again, another set of vital signs: heart rate 68, blood pressure is 90/51, respiratory 22, SpO2 of 94, and end tidal of 27. Now going up on oxygen to 3 liters nasal cannula. At 27 minutes, they initiate transport. They present to Peace Health for modified trauma, and then they later upgraded it to a red. So I think that, from my understanding, is initially it was a yellow and then upgraded to a red as the patient became more hypotensive. They repeat another 12 lead, which is very similar to previous, just a little bit better quality. And at 35 minutes, they get another set of vital signs. So another 9 minutes elapse from the last blood pressure, which is less than ideal for a patient who is going downwards in regards to blood pressure. So Heart rate 67, blood pressure 87/52, respirators of 15, SpO2 of 95, and tidal of 24. As you may note that he's never tachycardic despite this hypotension, but if I remember correctly, on that long list of meds, he is on a beta blocker, atenolol. So maybe that's contributing to why we're not seeing any tachycardia with this. Sorry, making you guys go through these EKGs again. Um, at 41 minutes, he gets another set of vital signs, largely unchanged from previous. They mix up a norepi drip, but ultimately they never give it, as they state that the patient seems to be improving and they arrive to the hospital. So the pulsar documentation, this was a red. They put in the vital signs, not tachycardic, hypotension at 90/52, respers of 20, and SpO2 of 95, GCS of 15, and a blood glucose of 170. The narrative they have is that the patient had nausea, vomiting with syncope, collapsed backwards and hit back ahead, no swelling, deformity or crepitus to note, no head pain, has chronic neck and back pain, history of bulging discs, is on Plavix, 12 lead, shows first degree, patient's hypotensive with pressures of 90/52. Although, if you remember correctly, it's actually been lower than that, but um, so in reviewing this case, the areas where I think that we did well at is that we got early set of vital signs, early blood glucose. We did get a 12 lead, although ultimately this was less than ideal. If you are worried about any ACS or primary cardiac, we really should be aiming for less than 10 minutes. They did get serial vital signs, although, as I pointed out, that when the patient started to become more hypotensive, it was closer to 10-minute checks. They did activate trauma. They reevaluated their interventions and they got pressors ready. Areas for improvement, they never did C-spine immobilization, stating that the patient's pain was all chronic to their neck and back. So in the emergency room, the patient received blood cultures, antibiotics, IV fluids. They thought that polypharmacy may be contributing to his presentation. He also was found to be COVID positive, and his CT imaging, which was extensive, the findings were for colitis and massive constipation and multifocal pneumonitis, not pneumonia. He had a 11-day hospital admission and largely just management of constipation is what was documented. This case was brought up by nursing as a complex patient that the ER doc was and the ER team was confused by, as it seemed like it was all kinds of things and ultimately ended up being a constipation and COVID patient that probably was further complicated by the polypharmacy. So I thought I'd talk a little bit about polypharmacy. Um, I don't know if you remember the patient's list of meds. If I remember my numbers correctly, that he's on 18 medications, which is a lot of medications. And considering every medication that we take has a side effect and a desired effect, and that we're weighing the pros and cons of these medications, there's 18 potential side effects just from the medications themselves, not considering the drug-drug interaction. So polypharmacy is considered whenever a patient is prescribed 5 or more meds to treat chronic conditions. Chronic conditions are any 2 or more chronic medical problems, which a lot of patients that we see have more than 5 meds and have more than 2 medical problems. So polypharmacy increases with multiple chronic conditions. Um, the difficulty in polypharmacy is that it's hard for the patients to manage, let alone caregivers that are tasked to help them with this, or family members. It's expensive depending on the cost out of pocket for the patients. It's difficult to track what if different prescribers are writing different meds and they're not paying attention to what the other person's prescribing. It can be difficult to track if they have multiple doctors, or especially if they have multiple ED visits. And then the possibility of drug-drug interactions. Patients that are getting polypharmacy situations are older patients, usually above the age of 65. So they tend to have difficulty remembering if they took the medication, if they took it at the right time of day, if they are taking it with a meal or not. and then obviously adverse effects of each of these pills as well as their interactions with each other. Patients over 65 make up 14% of our population, but they account for greater than a third of outpatient spending on prescription meds. So that's pretty enormous if you think about there's only 14% of our population currently, and the projected future is that that population is going to increase substantially. So we'll be seeing more polypharmacy situations, more chronic medical problems, and they'll be taking up more of the outpatient spending for prescriptions. So there's a lot of studies and research going into finding ways to decrease the amount of polypharmacy for these patients. They're working on deprescribing. They're working on getting all the team members of these patients that have complex medical diseases interacting and communicating with each other to try to limit the amount of meds that are absolutely necessary for these patients. And then what the patients can do is maintain an accurate medication list, and they can also bring their actual medications with them to either their clinic or to the emergency room to help in identifying what they're actually taking. When we take our patients from our nursing homes or assisted livings, getting that MAR is really helpful instead of taking all the pills and trying to keep track of where those pills get placed and that the patients don't lose them. But having a MAR to confirm what they're actually taking is helpful when they're coming from facilities. And then I thought that we can just talk a little bit about syncope for this case. So we've talked about syncope before. We're going to talk about syncope in the next case. So I'll go over it more here, but we'll recognize we'll be brief on the next one. So syncope is a loss of consciousness and postural tone resolving spontaneously without intervention. Some people call it fainting or falling out. Typically, it's abrupt on onset and resolves quickly. The patient may be awake and alert by the time that anybody interacts with them. Either that's bystanders, family, or EMS. And in pre-syncope is the sensation of having an impending syncopal episode, but not actually. Treatment for these patients is identifying the underlying cause for syncope and treating the specific protocol for that. So considering neurological evaluation or altered mental status. And we should be directing our time and efforts towards abnormalities. So looking for cardiac dysrhythmias, ischemia, hemorrhage, shock. So managing the airway, getting oxygen, evaluating for hemorrhage, getting IV access, cardiac monitoring, 12 lead EKG, monitoring treat arrhythmias. Again, we don't have it indicated here, but I would say if you're considering your syncopal episode is related to potential primary cardiac, then I think you should consider potential ACS, and our goal for Washington is 10 minutes or less. All patients suffering from syncope deserve hospital level evaluation, even if they appear normal with few complaints on the scene. So these are patients that would be against medical advice if they choose not to come to the hospital. And then high risk causes of syncope are in regards to cardiovascular or MI, aortic stenosis, HOCM, PE, thoracic aortic dissections, dysrhythmias, and neurovascularly can be hemorrhage or TIA or stroke. Anybody have any questions, concerns, thoughts regarding this case before we move forward?
I just wanted to say, I mean, I really appreciate how the crew really, took this patient seriously, got serial vital signs, did not, uh, just appeared to be thinking of all the serious causes of syncope. Obviously, syncope is more likely to be dangerous in the elderly. Other features about a syncope that make it high risk are if someone had syncope while exerting themselves, even in young people, that's high risk. Obviously, if patients had symptoms like chest pain or belly pain before the syncope, that tends to make it higher risk as well. And then syncope from seated or supine is generally high risk because that means that their heart couldn't even get enough volume even when in those positions to perfuse the brain.
Absolutely. All right. And then I guess, anybody have access to the chat to see if Ella is available?
saw her
Looks
log
like
in.
it looks like she's on the call.
Um, Ella, if you want to present your case, if you want to unmute, and you can just tell me to, or I can advance the slides as you go. And I know last time there was some problems with her mic, so if you are having problems, Ella, just call me and I'll put you on speakerphone on my phone.
Okay, is this
Oh,
working? Can you
yeah,
see?
that works. Perfect.
Oh my gosh, we did it. All right. Um, so it was 19-year-old male. Initial complaint was syncope with chest pain. He was working outside and his family called 911 because they said that he suddenly just grabbed his chest and started having a shortness of breath and then he passed out. So when we arrived, initially he was alert. He was breathing, but he had kind of his head was hanging down and he just seemed really out of it. He didn't have any obvious trauma or bleeding anywhere. And because it was a young adult, we weren't initially worried about thinners. Initial vitals were heart rate of 84, blood pressure 178 over 97, respiratory rate of 18, SpO2 is 100%. At 2 minutes, we did a 12 lead. He had complained of the chest pain and everything, so that was kind of our initial focus was the heart. He was having sinus rhythm, borderline tachycardic, but other than that, we didn't see any big red flags.
The one thing
And
I'd point out here is that for a young guy, his QRS complexes are pretty dramatic that you would kind of think of like hypertrophy. That's the one thing I'd add to that.
mhm. Yeah, and then apart from that, we were still concerned about cardiac symptoms just because of the presentation it was so classically cardiac that it didn't seem like he was having, um, it didn't seem like anything, dehydration didn't seem like an issue. He's grabbing his chest and having shortness of breath. So we were pretty concerned about his heart. That's why at 4 minutes we did another repeat 12 lead just to get a better idea. So that second one didn't change much. Um, but he was no longer experiencing the chest pain or shortness of breath when we got to him. So we weren't surprised to not find too much on that 12 lead. At 5 minutes, we had a heart rate of 95, blood pressure 157 over 106, and he was pretty stressed out, but he was starting to come around. And he was telling us that he didn't want to go to the hospital to get checked out, and we tried using his uncle who was at the house as well to convince him to go. And the uncle pulled me aside and said that he was just he didn't have insurance and he was worried about, he was from the Philippines as well. So he was worried about all the legalities involved with going to the doctor and paying for it. So we explained to them that we could, we would prefer that he goes by ambulance and that, we kind of explained to everything that we were worried about his heart. It could be a heart issue that we maybe aren't seeing now, but that we couldn't diagnose anything in the field and that he really needed to get seen by a doctor and get further evaluation. We even talked to him about the fact that he could die from a heart condition that was not, being addressed. He was so young, and for him to have had those symptoms and the way that he passed out and the symptoms that he had were not something that was frequent with him. He had no history of anxiety, no history of chest pain in the past, other than that at one other point in his life, a year prior to that, he had complained that it did happen before and he passed out. He said that he went to the doctor at that time, but he doesn't remember anything that they said or found. So that was also concerning. We did a blood glucose as well. I think it was normal. Yeah, 83.
83. Yeah.
Yeah. We called OLMC for the AMA refusal to try and get the doctor to also talk some sense into him and going, but as he cleared capacity assessment and was insistent on going, then the AMA was accepted and he signed the refusal.
Awesome. And so the good serial vital signs, serial 12 leads, documentation, online medical control for a high risk of refusal, and I really didn't have any areas for improvement on my review of this. Dr. Mock, do you have anything that you would have to add on the pre-hospital side of things?
No, it was just he had some T-wave inversion in lead 3, I believe.
Yeah, and
But
there's like this looks a little in the one in like the one in AVL and the lateral, but not really meeting any ST like I wouldn't call it a STEMI is what I guess I'm getting
no,
at.
no, I
But
agree. I agree. But I think, and I think the takeaway would, which was which you did here is like, he's got a concerning finding, had chest pain before, does not have a normal EKG. There are plenty of reasons to recommend this guy to go to the hospital, which I think was done. And as we've talked about before, getting the doctor on the line is not perfect, but you, in general, increase your likelihood that you'll get someone to go. When it's been studied, it's somewhere between 25 and 50% more people will go if you get them on the line with a doctor. So we've got our problems, but we that is something that we can help with.
Ella, did Dr. Chio Chan Kitman talk to them?
Yeah, she spoke directly to them, and which I loved because a lot of times when we call OMC, that we just talk to the doctor ourselves, and then they never actually talk to the patient. But this was one where I was really excited that she took the time to speak to myself and the patient, and told him very frankly that that he needed to be he needed to be evaluated. It wasn't safe for him to drive.
Mhm.
And that he should not drive himself, that he should go by ambulance. And so it was a really it was a, I mean, yeah, it was done well.
Awesome. Yeah, I agree. And the pre-hospital side of things for sure. So I included this case because I was in triage the next day when he came in and he presented for syncope and we got this 12 lead. I ordered some stuff in our triage area. I ultimately didn't take care of him, but the doc who did take care of him out of the emergency room was came up to me and was like, "Hey, that guy that you saw in triage." But anyways, so in the emergency room, he came in um, by private vehicle. I don't know if he drove himself or not, but showed up. He said he was moving some furniture and that he had a syncopal episode and had some associated chest pain. And then he had told us, which we all know this, we always get a different story, even if we ask exactly the same story, same questions. He said that this happened 2 times previous to the time yesterday, and that was all associated with playing basketball in that his initial troponin was detectable at 88, so mildly elevated but detectable. He had another troponin once he was roomed and seen by the other provider, and that one was stable and actually downtrending at 76. Um, this is his 12 lead, which, he's got what looks like really kind of big QRSs, especially these deep downward deflections. His T wave inversion is no longer present in lead 3, in that one in ABL, in the lateral leads V4, V5 don't look a little better than the previous one. So they read it basically as non-specific repolarization abnormalities. He was admitted for what they suspected was cardiac syncope because of his trope elevation, and they thought that his syncopal episode led to demand ischemia. They got an echo that showed a normal ejection fraction, and he was discharged on hospital day 1 with a Holter monitor, or not a Holter monitor, we call it a Zio patch or an event monitor. He, I believe he, what was, does it have the date? Um, uh, this was probably in July. He got discharged, and I don't see any other encounters. So I think that he was lost to follow up, unfortunately. But he didn't necessarily have hokum because that would have been identified by the echocardiogram. But I thought that this would be a good opportunity to kind of talk about syncope in fit people, especially with exertion, as this is a possibility of the etiology for their presentation. So it's a significant cause of death in young people. Men and women are affected equally, and that's across all races. Females tend to be more symptomatic, though, than males in that they usually presents in their second and third decades of life. This image over here kind of shows you a normal illustration of a heart, and then this one shows you hokum, which is this exaggerated or hypertrophied LV that decreases the amount of blood into the left ventricle, impeding the patient's cardiac output. Um, this is a condition that has a genetic component for inheritance and occurs in 1 in 500 patients. It can occur in any portion of the left ventricle, but usually it's more classically described as like the interventricular portion of the LV, and it can lead to outflow obstruction of the LV, which is 70% of the time occurs with activity, and it leads to abnormal diastolic function. The abnormal diastolic function, if you remember, is the part that actually provides blood or oxygenated blood to the coronary. So if there is diastolic dysfunction, they have an increased chance for having an MI. And then dyspnea is the most common complaint in symptomatic patients, as well as syncope, angina, dizziness, and palpitations. It's identified or suspected by history, as well as EKGs can show evidence of what looks like maybe hypertrophy of the ventricle, and an echocardiogram confirms it. And once this is diagnosed, there can be some lifestyle modifications, potentially decreasing activity or the extreme activity. Beta blockade can be administered preferentially over calcium channel blockers. And if they continue to be symptomatic, they may undergo a myomectomy of the septum or an alcohol septal ablation. If you have a patient with known HOCM, you should be really cautious about nitrates, as this can lead to further hypotension, as well as ACE inhibitors. So we talked about syncope in the last one. As a reminder, high risk causes of syncope: cardiovascular, MI, aortic stenosis, HOCM, pulmonary embolism, thoracic aortic dissections, and dysrhythmias. As Dr. Mock had previously mentioned, syncope that occurs at rest or sitting is concerning. Syncope with activity is concerning. All of it could be, but those are higher things on your radar to be worried about. Anything else to add for that case 3?
No, I would just add, and you see in the first ED ECG, the T wave is no longer inverted. And so just reminds me, and I'll talk a little bit more about it in PSEP, but as of October 15th, ESO has enabled the longitudinal record. In other words, it links the encounters for that particular patient over time. Right now, it's just within your particular agency, but you can see the previous visits. If you haven't seen it already on shift, here's an example of kind of what it looks like. But you have the opportunity to not just see what happened on the previous visits, but you can see previous pre-hospital ECGs. So obviously the focus needs to be on the patient and dealing with the patient in front of you, but this is another tool in the toolbox.
Awesome. That's like huge, especially when you're dealing with looking at old EKGs to determine not only cardiac, but also when you're talking about your presumed hyperkalemic patients.
And it essentially functions by taking their patient matching software and turning it on the database that's within your agency. So the better information that you get on demographics, the more likely you are to get a match. Obviously, the most accurate way to get demographics is by scanning the driver's license when that's possible.
Awesome. Well, that comes to review of the cases we brought up here. So neuroendocrine tumors, we talked about, these are tumors that affect the neuroendocrine cells, and that could be pituitary, thyroid, parathyroid, the lungs, the adrenal glands, pancreas, large intestine. Oh, I think I need to share again. Sorry. Um, are you able to see my screen now?
Yes.
Okay, perfect. So a reminder of neuroendocrine tumors, like that our first patient had, as well as patient perception even in the face of her first presentation, her diagnosis, and her last presentation, her perception. So remember that, the information that our patients provide is really helpful, but sometimes their perception of what's going on is not quite the truth. So using all your resources and as well as your skills to help figure out what the actual etiology that you need to manage or handle. Um, I thought this was kind of funny in regards to people that tell us that they don't have any medical problems, but they come out with greater than 6 medications. So polypharmacy, recognizing that the more than 6 meds for chronic conditions meets the criteria for polypharmacy and the complications of having multiple drugs and drug-drug interactions. And then lastly, syncope. Um, Considering the context is important, and then of your concerning syncable presentations is going to be, as we, third time talking about it now, is with young people that are active with any age that are not doing any type of activity and they just have a simple episode without a postural change, and having a high index of suspicion and recognizing the patients that really need to be urged to come in versus um, contributing to like a vasovagal event. That is all I have for you guys this month. Thank you for your time and attention. Please take an opportunity to give me some feedback on what works for you guys, what doesn't work for you guys, so that I can try to tailor this more to uh, what's beneficial.
Thanks for presenting. Appreciate
Yeah,
it.
absolutely.
Thank you, Dr. Gadwa.
Absolutely. Awesome. I usually stop sharing my screen, but tell me when I should stop sharing my screen since this QR code.
Yep, we can leave that up for a little bit. I'll also put a link to it in the chat.
Okay.
And thanks for being willing to present.
Yes, I was just going to say that. Like, thank you so much.